Okay, so I'm Tom Keeble, I'm a cardiologist in Essex. Hope I don't sound too bad. I've nicked this from Paul. I have a habit of nicking Paul's slides. I've stolen this completely from the front. I really like it. It must take him absolutely ages, and I just steal it and stick it straight in. So most of you know where we are. We are in Essex. We're just east of London, and we have a big cardiac centre that sees a lot of cardiac arrest, which is why we've developed such an interest in it. So as most of you know, to get out the other side of a cardiac arrest, these holes all need to line up. Everything needs to line up perfectly. You need someone to notice you're having arrest. You need someone to do CPR. You need someone to call for an ambulance. You need someone to defibrillate you. You need someone to, probably a paramedic or an air ambulance, to come pick you up and take you somewhere that knows how to deal with it. You need to often be fixed in a cardiac centre or elsewhere. And then, of course, the big missing link, which is why a lot of you are here and why we exist and why all this panel are here, are to try and make the follow-up of your problems and your issues better, because it's impossible to imagine what you've been through half of the time, and to think that you and your family wouldn't have any psychological issues is just bonkers. We're all human beings, and these things take huge effects on all of our lives, and we need to acknowledge that, and we need to develop systems that can manage it better, because at the moment it's geographically obscenely hit and miss, and I'm going to describe why that is. So I think you may have seen this slide before. We published this paper in 2013 showing that all comers to our centre, 67% of patients went home with a good neurological recovery. We were dabbing, high-fiving, really thought we were absolutely amazing, and we really felt as doctors we were doing a fantastic job. Now, while we were doing a fantastic job of the medical side, we were doing a truly horrendous job, or a non-existent job, I would say, of the follow-up of you guys, and we became to appreciate that quite quickly. So I love this photo. This is a new photo of the mugs and merchandise that have recently been printed, and I'll ask you to spot the obvious mistake on the first run. I've previously stolen Paul's bucket in head one, which is upside down, but so I don't have to steal another one of his slides, I've chosen to make a new slide. But this is stolen from Ingrid, who kindly gave me this. I think this has huge value. I think this, there's only one of them in the world. It's in Ingrid's sink currently, but I think it just shows, just helps us understand what you go through, and it's a challenge. So after the trial that showed we could make people survive 67% of the time, which we were pretty happy with, I followed everybody up routinely as a matter of course. And the first one in February 2013 said, "I wish you hadn't bothered, doctor." He came with his wife, they were both crying, and I went, it's a bit disappointing. I thought we'd done quite a good job here. Not to be deterred, the second one came in and said, "I don't have a life worth living." Blimey, this really isn't going well, is it? There's huge problems here. And this is stolen from Paul again, and Gareth, as is the Abyss photo, which, we now understand from following these patients up that it isn't straightforward. And if you ask any cardiologist and says, "I don't think I see patients like that," it will be because he doesn't see any patients, or cardiac arrest patients per se. So we know these problems are there, and we just need to create a better follow-up matrix. This is a slide from your group, and I think don't underestimate the power of your group. You are, in my view, the biggest and most effective cardiac arrest group that there is on the planet. Within 24 hours, Paul gets 149 respondents saying that, in essence, my in-hospital care was terrific, my post-discharge care was rubbish, and I need loads more help. That's my simple take-home message, and whenever I talk to any one of you guys, it's pretty much that message, and I think that is an important message. But it's more, we can cut down even more than that. It's about that if you don't have a heart attack, which many of you won't have had a heart attack, you get even more abandoned. You don't even get rehab. You don't get anything. You get a GP appointment with someone who says you're lucky to be alive. So there really is nothing for you idiopathic guys and others, and we need to make that better. And as most of you know, there is a real lack of psychological support in the community to make these things better. So, is that the same with other conditions that cause brain injury, like stroke? So stroke is very common, lots of brain injury. The guidance is huge. So NICE say that if you have a stroke, you have to have everything assessed and given everything every day, 5 times a week. So if you have a brain injury, it could be a really small brain injury, you get cognitive functioning assessment, emotional functioning assessment, communication assessment, self-care, vision, swallowing, movement, all beautifully laid out. You get this every single day without fail. You get all of these people into your care in a pathway. Has to happen. If it doesn't happen, people get fined, and it's all just very, very messy. These are guidelines. Now, if you then look at what happens when you guys have a brain injury or a psychological problem following your cardiac arrest. This is what the most recent document from the Resuscitation to Recovery document says, and it says, oh dear, there's a lack of neurorehabilitation services and we should try and provide what we can. You know, waste of time, complete waste of time. And so we need to create evidence to create a pathway that gives everybody a fair chance of getting what they need. And so why is the disparity? Why, if you have a stroke brain injury, do you get everything? And when you have a brain injury or a psychological problem related to a cardiac arrest, do you get nothing or next to nothing or randomly assigned? Well, there's a few things. First of all of the resuscitation guidelines are written predominantly by pre-hospital doctors and by intensive care doctors who don't then see patients. They don't follow patients up for toffee. So if you deal with those people doing the guidelines, why on earth would they think there's a problem? They might accept it from the literature, but they've never seen it firsthand. So you see an ED doctor, you see a pre-hospital care doctor, you see an anaesthetist, you might see me and John in the cath lab, and then you see often a defibrillator EP device doctor. There's a problem with ownership then. So do I own the patient as a stent doctor? Does the EP doctor own the patient as an EP doctor? It gets lost in translation, and that's really, really important because continuity of care is really difficult in the NHS, but is vital to give you what you need. And at the moment, that is one of the problems. If you come in with a stroke, you go into a stroke doctor. Pretty straightforward. So this is one of the complicating factors that we need to make better. So how have we helped people in Essex, and what would we argue would be the model to make it better across the whole of the UK and then beyond that? Well, we've got Marko on here, who's a neuropsychologist who tries to see the patient as an inpatient, as well as our inpatient nurse and rehab team. We've done a video, which some of you may have seen, lifeaftercardiacarrest.com. It's a 14-minute video expressing to you the problems that you may experience in the first days and weeks as you recover. We have a very developed, I would say, care after resuscitation team, but it's currently half funded by the hospital and half funded by charitable funds. So this is not sustainable. This is not something that can be rolled out everywhere in this degree because it's too big. You can't expect every hospital to do this. It's too expensive and too big. But we need to capture more information, capture more data and more need and publish that, so that we can ensure that we do the right thing for our patients up and down the country and across the world. I wanted to bring in Neil here. Neil has run our care clinic, and he's in the audience, probably doing his counselling now as we speak. Neil set up our clinic about 4 years ago and has done the most incredible job, taking it from zero, from nothing, to now a really fully functioning system. So I just wanted to acknowledge him because he's incredibly important to us, or has been, but he's moved on to a new job and we have to move too, but he's been amazing. And anyone who gets a chance to talk to him will realise why. We have a counsellor that I've just got funding for on a Tuesday afternoon that can see 4 patients a week, and Marko is now funded 2 days a week as of next year, which again, for us is fantastic, to have assessment, research and treatment abilities 2 days a week, just in cardiac arrest patients. Amazing. But again, half funded by SADS, so let's not pretend this is research and clinical commitment. So this is what our service looks like now, and the key thing is that you cardiac arrest survivors and your families need to be have an understanding and educated about the transition from your hospital bed to your home and all of the problems that you might have, and you then need to have tapped into all of the facilities to make that better and the healthcare professionals that can make that better and accept what the problem is to enable you to have the tools to make it better. And again, we don't do that very well. This is new for next year, so we've copied, they did the first one ever in Denmark, which was presented in the Swedish meeting recently. Let's imagine that every one of you, within 4 months, had a cardiac arrest retreat. A bit like this, but with other survivors, with my guys all on in this retreat, letting you support one another and then us supporting you too, within 4 months. So we run it 3 times per year. And in Essex, that's what's going to happen next year, which is going to be truly fantastic. So I think that a lot of the problems that you might run into later down the line may be addressed in an easier way. And again, completely funded by a local charity. But you have to start with these things with charitable funds and move onwards and upwards. I've passed that. So this is the next thing. It's all well and good. Although Paul had a terrible experience in Essex because we hadn't started it at that time, and he was part of the reason why we developed it, we need to, Essex is fine now, but that's not good enough. We need to, you guys don't all live in Essex, and I wouldn't want you to either. It's not, it's a bit too busy, a bit congested. we need to make it better from our experiences across the whole of the UK, but in a way that is scalable, deployable and deliverable. There's no point in saying you need a psychologist 2 days a week, you need this, you need... It's not going to happen. So we have to make it, if you like, bare basics to start and then let it build. Once it's there, let it build. So what we propose is this, which is what we've called the cardiac arrest recovery team. Now, team, in my view, can have one person in it if that's all you've got. So if you've got a small hospital up in Dumfries or whatever, your cardiac arrest recovery team may be a rehab nurse. That's it. That might be all you've got. But what we need to ensure is that rehab nurse is skilled and trained in picking up the problems you guys have and then pointing you to the services that Dumfries has, which might not be a lot, but it will be whatever it is. Does that make sense? And that is scalable, deliverable, quick, cheap, easy, and I think potentially hugely effective. So we plan as a group, all on this table, to upskill a CCU nurse, an ICU nurse, a rehab nurse. We don't mind who it is. It's someone who has to understand the condition, but that we will upskill them. All these lectures are being videoed, as you've seen here, to go on our website to train other healthcare professionals who maybe don't see so many cardiac arrests as we do. We see 125 a year. Maybe they only see 15 or 3. They need to have these skills to improve things. So we want them to understand the emotional and cognitive needs, signpost early for whatever is available locally, which may be lots, maybe not a lot, and partner with your group to make that a palatable, wanting solution, not just something that we think doctors think is a good idea. It has to be, we're trying to work around the other way, that the patients tell us what they want, and I think that's the way to work. And that we want a minimum care offering. So as I say, anywhere in the UK, the minimum offering probably will be 2 rehab sessions for 1 hour each with someone who knows what the condition is about. Probably not enough, but that's a great minimum start point. And I'm talking with Paul actually next Friday at the British Association of Cardiac Rehab Nurses to put this concept forward and say, rehab nurses, please, this is a big problem, let's do this. We'll train you, here's all the documents, here's all the videos, the webinars, and they'll get a sort of, they'll get capable of doing it, and then hopefully we can roll that out. But we need buy-in. We have the Resus Council UK who have very, very kindly come to listen to us today, and I think they need to hear what we think as doctors and healthcares and what you guys think, more importantly, as patients and survivors and families, about what you want. So this was a PhD in Holland by Veronique Malert, who helped us set up our cardiac arrest clinic in 2013. She wrote this in 2010 and published it in 2010 and had difficulty publishing it. The community didn't want to listen to her. She was right from the very outset. The brain is the heart of the matter. It's really, really important for all of us, survivor or caregiver, really important. I'm very excited about this. The Care Clinic yesterday did a newsletter of updates as to how patients are done. If you go to lots of cardiac arrest centres or even just any hospitals, their perception of cardiac arrest survivors is they don't do very well, they really struggle, they often die, which in some circumstances is true. But in our centre it's not true. 67% do very, very well. And so we want the anaesthetists, the cardiologists, the nurses, the doctors to be fed back as to how they all do. So I got a lovely email yesterday. They don't mind me sharing this because they've signed consent to share it. 2 patients, Mr. Ashton, he's back at work. His mates can't believe it because they did CPR on him and he's back straight at work already. Mr. Barton, he's walking the dog in Leon Sea with his wife, delighted. And then telephone follow-ups. One's at home doing the hoovering ironing, which is never a good thing for a bloke, but there you go. So I think that, you know, this is what we need to do to educate ourselves, that the outcomes can be good, that you guys do well but need support and need to put that in place. I'm not going to steal Karen's thunder. This is, Karen and I met in Lund with Paul. We're setting up, and I'm not going to talk about it because she's talking about it, but ITCAR you're going to hear lots about. It's the International Task Force of Cardiac Arrest Recovery, and it is exactly what it says on the tin. It's interested people like this entire table following it, you guys, and suggesting ways in which we can make it better. Very simple, but it's going to be global. It's not just going to be Essex, it's not just going to be UK, it's going to be global. So it's going to be us, it's going to be the guys from Melbourne, it's going to be the guys in Lund, Copenhagen, Holland, Toronto, New York, that's not US, Pittsburgh, and New York. So it's going to be a real collaborative piece of work to make it better. We have to talk to the world to get people to listen to us. That's it. So I really appreciate your time, and as I say, Please, as Paul says, make the most of this day. Come and talk to all of us. Interact with each other. Go home in a better state than you came, in whichever way that is, and work together for a better solution in the future. Thank you. How was the time?